everybody, and welcome to day 2 of our 8th annual Global Supply Chain Summit. As Wink mentioned, that yesterday was really a jam-packed agenda from morning kickoff of Outlook 2025 to really taking into how the digital transformation will change the landscape of global supply chain management. And going forward today, we're going to reinforce some of those incredible transformation that's happening during the COVID and post-COVID with incredible lineup of speakers and panelists throughout the day. So with that intent, I would like to kick off the day and hand this baton back to Wink to introduce our first keynote speaker of the day.
Okay, thanks, Nick. Now it is day 2, and we do need to comply with these quirky California rules in taking people's temperatures at virtual events. So if you could put your foreheads up to the screen real quick, we'll take everybody's temperature here. Oh, 97.6. Very good. Okay, a little cooler than yesterday, so that's good. So now we can continue. So I would like to introduce a dear friend of the center and the Vice President of Global External Innovation at Johnson & Johnson, Dr. Pierre Theodore.
Thanks, Wink. I really appreciate the introduction. And Nick, great to be with you once again. Surely this is truly one of the world's leading conferences in supply chain management. Could not appreciate more the opportunity to discuss some issues that are very key to us at Johnson & Johnson with respect to supply chain issues related to COVID-19 and beyond, and what we might call the sort of the first and the last mile of the healthcare supply chain. That is where the clinician, him or herself, interacts directly with the patients, and how that last portion of the distribution of goods and services is actively changing. I come at this topic really from 2 different perspectives. One as a Vice President of Medical Affairs at Johnson & Johnson Global Public Health, and also as a practicing cardiac surgeon, as I am on the adjunct faculty at Stanford University at present. And I'm going to try to weave together 2 stories today. And really it is a story of how mobile healthcare can create a distributed network of the delivery of healthcare services. But I'm going to discuss that in the greater context of healthcare disparities and how there are significant differences in how different populations both experience healthcare delivery and the outcomes that are achieved. So I'm going to do my best to weave those 2 stories together in this brief discussion. This observation back in March and April really set off some of the work that we are engaging in at Johnson & Johnson around healthcare disparities with respect to COVID-19. This is chosen specifically from Michigan, but similar data has been seen nationwide in New York and in New Orleans and in Los Angeles, where there is a significant disparity in the risk of death and major morbidities related to COVID-19 based on ethnicity. So for example, in Michigan, where the African American and Black population measures 8 or 9%, roughly 40% of the deaths were associated with the same population. So a roughly 5-time increased risk of mortality in African American populations versus the overall population, or in comparison to white patients. And this is the very sort of evident definition of a healthcare disparity. And I want to just take a quick second to define what disparities and what equity effectively means, so we can go forward to address this issue of how one element of the supply chain can address this. Now, health equity is really the promotion of opportunity to health through addressing obstacles such as racial, gender, ethnic discrimination. And really the consequences of that, which are a lack of access to care, and I would go even further to say the ultimate consequence of this is an impairment and is poor health outcomes. And health disparities are really the inequalities, but inequalities that are closely linked to some form of socioeconomic disadvantage. And it's usually linked to some legacy of a systematic discrimination that puts in place obstacles that prevent access to adequate health care. You know, this has been outlined very carefully in some work that was done almost a generation ago by the Institute of Medicine to demonstrate that the impact of these disparities can be reflected in life expectancy across the United States. So you can even have in one city, for example, such as Chicago, differences in life expectancy that might vary from 20 years given on the zip code in which you inspect. And when we start to tally up these healthcare disparities in terms of causes of death or leading causes of death in the United States, we note that nearly 100,000 deaths per year in the US can be attributed to ethnic and racial disparities in access and ability to gain access to healthcare. And when we stack this up against major issues, let's say, for example, like lung cancer, this is sort of how we sort through things in part at J&J, where we ask, what are the major unmet clinical needs affecting humankind, and then try to address them. You can see that 100,000 deaths a year specifically related to healthcare disparity is quite significant. 200 to 250 US deaths per day directly attributable to ethnic and racial disparities in the US. And this is the city where I grew up in, and each one of the little tiny blue dots on the left actually represents an individual. You can think of that as a household, and what you see is that where you live corresponds pretty closely to the longevity, which is seen on the right. So there are clearly determinants related to social factors that determine longevity in a population that's reflected in differences in clinical outcomes and in life expectancy. And it's not just a matter of the moral imperative of the healthcare outcomes, but we also know it's extremely costly. $230 billion in direct costs over just a course of 3 years in work that was done by Tom Leviste a few years back. And we know that many of these additional costs are due to issues around failure to screen for disease or management of chronic diseases like diabetes or hypertension, therefore leading to cardiac disease and stroke. And we know that this causes a tremendous economic burden to the tune of billions, even trillions of dollars of indirect costs in the United States. So this is not an insufficient issue, a small issue. And what we know is that many of these determinants of these differences in healthcare outcomes span all sorts of domains. They span domains of the economy and of neighborhood physical environment, and then they eventually move over into the healthcare system itself, which is things like provider availability and cultural competency. Now, the truth is that many of these things are outside of the purview of a healthcare company, but some of them are well within our capacity in a healthcare company to influence, particularly how products and services are delivered specifically to the customer. And I say customer in between air quotes, in as much as the customer varies from hospital to patient to physician that is delivering the care. And importantly, when we consider these determinants of health, things like transportation or the ability to gain access to healthcare systems are very important determinants of overall healthcare outcomes. This is a cartoon that proves that you are in the presence of someone that is clearly not a health supply chain specialist. As much as in this very basic view, what we often tend to see is that the end of this supply chain is really with the patients or clients or the delivery of a product and a service to a node of delivery, such as a hospital or healthcare center, an outpatient surgical center. But the real end of the healthcare supply chain is the value that's generated through healthcare. And so to the far right, and I just picked one simple example, which is infant mortality rates in St. Louis, for example, we notice a significant difference along ethnic lines. And so the real success of the supply chain is reflected in the end result, which is the value generated by improved standards of health across a population. But it's important as the supply chain, starts to get closer to the patients and the clients themselves, there are significant barriers, everything from cultural competency to how do patients and clients physically access the products and services. And this is where that last mile issue of supply chain dynamics become quite important. There are many lessons that have been learned in the past that have not been applied. And we know for a fact that often we need to hear a lesson more than once. This is some interesting work from Anita Patel's group at the CDC, around the limitations of the US supply chain with respect to personal protective equipment that was well known back in 2017 and had been lessons that were learned from the 2009 H1N1 epidemic, that there would not be the capacity to upscale production to allow for management and for the continuous delivery of personal protective supply or equipment to clinicians. And so these kinds of lessons have been appreciated before, and I think have once again come back around due to COVID-19. And when we think about the last mile or the first mile of healthcare, and I sometimes say it's both last and first, is that sometimes the demand is generated from that connection between clinician at the point of care. It's a short geographical distance, but there are lots of broad cultural and allocation divides that have to be spanned to provide quality healthcare service to the patients. It's costly and expensive and labor intense, and often it's unappreciated the fragility of that last line of delivery of care, that last mile of delivery of care, with how patients actually access products and services. And what certainly has come about is that due to COVID-19, we have both challenges in improvement of population health, but also opportunities. So that, for example, expanded use of telemedicine and hospital care at home is self-evident. Here's an example from UCSF Medical Center in San Francisco of the difference in the number of virtual doctor visits from February at a couple hundred a day to May of a couple of thousand a day, and continuing to expand over time since then. And this is not going back. And I can say that because of new legislation put forth in California that has passed to allow for reimbursement for more virtual visits and a lowering of many of the privacy and security demands that will allow for exchange of healthcare information. So the face of how healthcare is delivered at the quote point of care is changing dramatically. This is a somewhat complicated slide that just came from an editorial that was just published last week in the New England Journal of Medicine, but it's actually quite important in as much as it points out that the key to COVID-19 is quick and quote dirty, and by dirty I mean lower sensitivity tools that will allow for the recognition of early cases before patients are known to be infectious and can spread the virus broadly and widely. So being able to get to patients early and quickly, often before they are even necessarily symptomatic, is key, and a very quick turnaround to the delivery of the information is key to the ongoing management of COVID-19 and frankly COVID-20 through 100 in subsequent pandemics that we will face as a species. Now, I should also point out that the key is not in-house management or in-hospital management of complicated disease, but how do we get to patients before they're often highly symptomatic? And the fact is, to get there, we have to bring the care directly to the patients. And this brings us to one element of the supply chain where J&J has now become an active player, which is how can we begin to promote mobile care technologies to promote testing of COVID-19 and allow us to address these issues earlier in patients who are asymptomatic. And to this end, we have three basic goals through community partnerships with public organizations that are able to deliver high quality COVID-19 testing at low cost, through increased reach and impact to patients who are vulnerable populations impacted by the disease of COVID-19, starting off in two large urban areas, as I mentioned earlier, with a disproportionate impact in Black and Latino populations, and with a goal towards healthier communities, and also to sort of create, if you will, a model of data-driven advocacy for improved access to healthcare for vulnerable populations. So there are a series, as we draw this discussion to a close, there are a series of important lessons to be learned from healthcare in the setting of COVID-19 that I think expand across industries with respect to supply chain dynamics. We certainly understand the fact that there are changes going on now in terms of reimbursement and how healthcare will be delivered beyond the sort of traditional brick and mortar elements of the healthcare in hospitals and small medical centers. Call this an Amazon effect of a increased distribution nodes, so things like mobile care delivery and care at home in order to to improve overall improved healthcare outcomes. And secondly, that we anticipate and will need greater degrees of collaboration among the supply chain leaders themselves, but also clinicians and data scientists. It's no longer acceptable for clinician leaders to not understand the supply chain demands in terms of substitutions that are required under given pressures from dynamics that may be changing rapidly in the time of a pandemic, for example. And this last point, I think, is critical. We live in a time of decreased trust from everything from our political leaders to institutions. And yet, in facing pandemics and in facing public health demands, trust is absolutely critical among manufacturers, distributors, public health agents, public health officials, and government agencies and the like. So continuing to demand increased transparency and visibility across the supply chain is key to this ongoing development of trust. And I will end by saying, one might ask, why is Johnson & Johnson particularly engaged around this issue? It's because it's really core to one of our values, which is to put the patient first and then to come up with solutions to address unmet clinical needs. So with that, I'll turn it back over to you, Zink. And again, I very much appreciate the time today and the ability to discuss this critical issue with each of your participants today.
Thank you, Dr. Theodore. I feel like I just watched one of the best TED Talks of all time. That's a great presentation, and I hope it gets out beyond just this audience. So I was going to ask you just a follow-up question. How soon do we get there? What's the timeline of this?
And some of the changes in reimbursement patterns are happening, Wink, as we speak. And as I showed that one graphic, that increase in telemedicine as really a strategy for healthcare delivery, it is happening now. And for those who may be listening in, if you look at an organization like One Medical in Northern California, which is really challenging this idea of how do we both diagnose, evaluate patients outside of a medical care system, we see real-time changes in how healthcare is being delivered. So I think the future, to answer your question, is actually happening as we speak.
So Pierre, great presentation, and thanks for joining us. So as you know, the theme of the conference is Supply Chain Outlook 2025. So obviously we're pivoting post-COVID world, looking at the digital transformations underpinning those are the trends that the center has been talking about, decoupling of supply chains, primarily out of China, looking at beyond just the telematic healthcare delivery system. What are the trends you from the Johnson & Johnson standpoint, but specifically in general, that you see that will transform the way we define supply chain going forward?
Yeah, I think one of the most important things here is what you might call value-based care, where we now consider almost at a population level. So it is important, the individual interaction with a patient, but it's also how well are we actually creating levels of improved levels of health in a population? And how can we create value and begin to bring products and services that are designed not just for a sort of case-by-case reimbursement strategy, but more for population health. So I think an increasing trend towards value-based care is no doubt an important trend for us in healthcare, and one that we're trying to harness at Johnson & Johnson.
Thanks, and just a quick touch base. I mean, I know the low resource environment, they're struggling during the pandemic even more so, because we talked about very US-centric conversation. How does this really goes beyond the borders?
Yeah, no, it's absolutely a critical issue. And obviously, as a global company, we find responsibility to address those who are really at the lowest end of the healthcare pyramid. And we think we largely do that through public-private partnerships. This is the opportunity for the private sector to connect directly at the government and Ministry of Health levels to understand their chief healthcare demands and then to try to come up with innovative solutions. So we find that handshake, if you will, between the public and the private sector absolutely key to addressing at a global level in low resource environments and addressing the healthcare needs that you bring up.
Excellent. Thanks again, Dr. Theodore.